Thank you, Shweta ma'am. Archana ma'am, you can go ahead, please. Thank you so much.
Okay. Good evening, one and all, and welcome to this second Regional Anesthesia Fellows Assembly. We've gathered all here today, especially, with the examination in mind, okay, for all of the hard and grueling 1 year of work that you have done. So before we get started, I'd like to welcome our Academy of Regional Anesthesia India President, that is Dr. Javed Khan, to please deliver the welcome address. Sir?
Thank you, Archana, and good evening to all my esteemed faculty, distinguished fellows, colleagues, and dear friends. It's given me an immense pleasure to welcome you all to this Regional Anesthesia Fellowship Assembly. This is truly a platform that reflects the academic spirit, clinical excellence in the regional anesthesia community. Academy of Regional Anesthesia always believes that these structured fellowship programs are the backbone of academic excellence. The standardized curriculum, hands-on training, mentorship, the researches, we aim that every fellow who is stepping out of the program is a confident and a competent one. They are the future generation, they are the next generation clinicians, they are the leaders who will carry forward the legacy of regional anesthesia with innovation and compassion. So, my message to all fellows is sort of encouragement to learn with the curiosity, to question with courage. And if it will be unjust if I don't mention my appreciation to all my faculties, mentors, all the members and executives of Board of Studies of ARA, whose dedication made this assembly possible. Your commitment, your teaching, your guiding the young anesthesiologist makes ARA a vibrant academic family. So I wish all the participants a productive, enriching, inspiring academic experience. Warm regards to all. Thank you so much.
Thank you so much, sir, for that lovely welcome address. Moving on, so before we get into the real nitty-gritties and the case discussion, I'd just like to address all the fellows present here and also the mentors that are present here. I'd just like to appraise you about the exam pattern that we have gone through and also what is there in store for the upcoming exams. Okay, with that, I'll just quickly share my screen. Okay, is my screen visible?
Yeah.
Yeah. Okay. So at the outset, my name is Dr. Archana. I'm sure I'm the controller of the examinations for now. I've been conducting the exams for the last 2 years in conjunction with the Board of Studies of AIORA India. So basically what we have here is a common exit exam wherein as you know, we have fellows from all across the nation. They span from the north to the south across 21 centers. And we have around 35 students attempting the exams in the next current, upcoming fellowship exit exam. Essentially, what is it is, it's the culmination of a rigorous and a post 1 year postdoctoral fellowship, which is offered by the Academy of Regional Anesthesia India. Okay. The exam is basically conducted twice a year since we have two admission sessions, that is the Jan and the July session. And it is all conducted at a common center, which provides adequate and transparent infrastructure required for the apt conduct of each exam. To be eligible for the exam, each of the candidate has a set criteria that is defined clearly by the Board of Studies in the curriculum that they need to fulfill before they can even stand eligible for the exam. It is conducted with as much objectivity and transparency as possible. Okay. So the overall format is basically it's a 200 mark exam. They have a theory part and a practical part. The passing score is you have to score a minimum of 50% in both the aspects. A distinction is anything considered above 75%. And of course, the distinction candidate with the highest mark is eligible for the gold medal for that academic year. This includes both the Jan session and the July session candidates as well. So the theory exam is essentially 10 short answer questions of 10 marks each. Each question can have a scenario and little parts in between with set marks that are allocated, that if you answer the question according to the point, only the allocated marks will be awarded. The question paper is set according to a basic blueprint, as you can see it on my screen here. So these are most of all the time, the questions will arise from these set topics as well. The correction is done by 2 independent examiners who will not be aware of who the candidate is that they are correcting. Okay. Then the practical exam, it's conducted at a center which is to avoid conflicts of interest, wherein there are no fellows at that particular center, or that particular fellow is designated to an opposite center. 4 examiners examine all the 4 candidates. And this time we have changed the format a little bit. The syllabus and everything is the same, except that we wanted to allocate more time for a strategy and a skill assessment basis. And that is why this time from henceforth, we will have a strategy discussion alone of 2 cases, which will be for 40 minutes, a skills assessment station where the candidate's demonstration of the skill alone will be assessed for 40 minutes in all body aspects. And we will have 5 OSCE stations for 3 minutes each, wherein you will have around 2 to 3 very objective questions that you need to quickly answer based on a spotter. Now, the spotter might be a drug, it might be an equipment, it might be a video of a sonoanatomy, it might be, even just an anatomy picture. So this is the overall outlay of how the exam is going to be conducted and how the candidate is going to be examined in their regional anesthesia curriculum. So next, the last and least thing is but not least, is the logbook and how you showcase yourself. Wherein the logbook is not considered for your pass or fail. However, the logbook does distinguish the gold medal candidate when in case there is a tie. So as you all know, this is our defined logbook dossier for the fellows to be filling up. So this is how the logbook is graded. Okay, based on how they are graded, the examiner who will allocate a mark based on the quality of the logbook papers that are filled. Please do ensure that your dossiers are countersigned by your mentor, because that just adds genuinity and it showcases your work that you've done across the 1 year of your fellowship at your institutes. Okay, so all the best, everyone. I wish all the fellows all the very best. Please don't be nervous. Just attend the exam. All the examiners are your friends, and they're just here to make sure that you become the best of RA, as Javed sir has already mentioned to you, that you continue in this tradition. Thank you very much. With this, I will hand it back to Dr. Sangamitra to conduct the next sessions. Thank you very much.
Thank you so much, ma'am. Thank you for the detailed description of the classes and exams and encouraging the fellows. We'll go ahead now with Shruti's presentation. Shruti, welcome back. We all want to hear your success story. The fellows and we are equally interested to go ahead with it. Welcome, Shruti.
Hello. Good evening, everyone. Are my slides visible?
Yes, Shruti.
Okay. A very good evening. My name is Dr. Shruti, and I very recently completed my ERA fellowship from St. John's Medical College. Today, I'm here to give you all a very short talk on how I prepared for my ERA exams and how I attempted it and how it resulted in a very good result. So, when it comes to your theory exam, the first thing that I would ask you to do is please go back and look at the Academy of Regional Anesthesia question papers that have been there over the last 3 to 4 years. And this year, I saw on the group very kindly the faculty are sharing the entire archive of papers. So please go through that. And when I was studying for my exam, I did the very same thing. I looked at a couple of papers and I found, as ma'am had mentioned earlier, that there was a pattern in which the different topics had been allocated over the question paper. And if you follow this similar pattern, you will make sure that you're covering all topics before you write your theory, and it also greatly helps when you are attempting your practical exam. So firstly, obviously, there will be questions that come down to what is the RA strategy for a specific surgery. So I've broken up the question paper of mine, the one that I attempted. And because I follow this pattern of studying, I realized that it helped greatly. So initially what I did is I broke down each surgery group into this. So like you all can always go back to this video and look at this slide. But these are the most basic and possible different surgeries that they will ask you about. Like, what is your RA strategy for this specific surgery? And if you can look at the question on the top, there are see, they have twisted it a little bit. They've mentioned that the patient is having multiple comorbidities. So that comes down to your basic anesthesia knowledge. So, but if you when you are preparing, you do this, like say, okay, for clavicle surgery, what is my RA strategy and what are all the other options? So this is important. So your option and all options. So either you will say, either the question will be, how will you give regional anesthesia for this specific case, or what are all the other possible options that you can use to give regional anesthesia for this case. So if you follow this pattern, you will make sure that you're covering each and every one of these specific surgeries. And when you are, I've highlighted that surgical dermatome, minor osteotome, because that is what helps you decide which regional anesthesia strategy is going to work for that specific case. So if you're going to do clavicle, know what is the involved dermatome, myotome, and osteotome, and based on that, you can pick your regional anesthesia strategy. Then the next set of questions, like the next possible question that you'll get, is obviously a specific block. So this is again from my paper. We got different approaches to a sciatic nerve block. So again, when you are studying, if say you say upper limb, so choose all the blocks that are there. So supraclavicular, interscalene, and then you break the, like you study based on what are the, what is the like, if you're say, like you're saying, see, I got this question on sciatic nerve. So what are the different approaches to sciatic nerve from top to bottom? So if you follow that, if you get, see, these are the subtopics that you can use: indications, contraindications, anatomy, sonoanatomy, landmark, USG, PNS approach, ergonomics, equipment, drug choice, volume, complications. So if you follow this order, you will make sure that for each individual block, you have covered all the relevant topics that will come under it. The next set of questions that you can get is anatomy. So we got this really nice question on shamrock sign. So what are all the blocks that can be given once you identify the shamrock sign, which is a very innovative question. So anatomy can be something like this, either sona anatomy, or it can be like draw the brachial plexus or draw one of the other plexuses. So again, when you're studying, make sure that you're covering adequate anatomy. I went back to my first year anatomy textbooks. I read Chaurasya, and I made sure that if I'm going to study the upper limb, I did the entire anatomy from the neck till the hand down, all the muscles, all the nerves, all the arteries. So that gives you a very comprehensive understanding, and you'll be able to answer your practical and your theory very well. So make sure your anatomy, your sona anatomy is solid. The next set of questions are drugs. So these are all the possible drugs that are there. The drug, the categories that come. So you'll have either local anesthetics, and we had a very nice question which I remember reading for my PG exams. So it is a very detailed question about the pharmacokinetics and pharmacodynamics of the local anesthetics. And these are the other possible subtopics. So adjuvants, anticoagulants, antiplatelets, opioids, sedatives. So you should know these specific drugs in and out, and you will get asked these similar questions even in your practical exams. Then next comes down to equipment. So there will be 1 or 2 questions on equipment. It is a large topic. Make sure that your needles, your catheters, your ultrasound physics, especially artifacts, and PNS. Your PNS you should know in and out, because this again you will be even asked in practicals. So at least these specific equipments you should know like at the tip of your fingers. But also I've mentioned that miscellaneous. So for your practical exams, keep in mind that you will get asked questions like on, like say the infusion pump, dosifusers. So you should know the basic physics and the working of those kind of equipments, everything that you're doing with RA. Then the next set of questions are complications. So you have your standard PDPH, last, peripheral, a nerve injury. So those, all the possible complications, you might get 1 or 2 questions based on it. We got 2 questions. We got on last and on PDPH. And then this is what sets you apart from the rest of your colleagues. Okay, make it a point to go back and read what are the standout landmark articles that have come out in the last 2 or 3 years in relationship with regional anesthesia. Things that have changed the very practice and understanding of regional anesthesia. So especially guidelines. So this was a wonderful question that we got. There was a paper that came out in I think this is 2022, if I'm not mistaken, which very beautifully broke down the anatomy of the thoracic paravertebral space. And the entire question that we got was based off this paper. And I was so happy that I had gone through this paper and watched a video on it, because I was easily able to answer this question and also understand how beautiful the minute details of the thoracic paravertebral space were. So make sure that you've gone back and looked at like the last 2 to 3 years of very important articles. So in my like a small tip that I would ask you, like this year, because you know that there's a new update in regional anesthesia and anticoagulants, antithrombotics, or there is a new update on infection control practices. So these like things that have made a landmark, they've made a big difference to our regional anesthesia practice. Those are the kind of topics that you will get 1 or 2 questions on. So make sure you've read it. And last, of course, bouncers, things that you can't predict. We got this very interesting question on how you would set up a block room. So that again comes down to practice and your extensive knowledge. But like something that I would anticipate this year, like some question on AI, because there have been a bunch of articles that have come out on regional anesthesia and AI. So these bouncers are some things that you can't predict, but if you have done like a light reading, you should be able to at least attempt about 6 to 7 marks out of 10 marks. Now coming to the actual tips for writing. So please make sure that you are sitting in a quiet room which has very good Wi-Fi connectivity, because you are doing this exam in on like you have the video call with the Zoom link running, so that you are supervised by the Aora BOS while you are writing your exam. And I made the mistake of sitting in a very dingy room with there were like multiple boils machines, and I was sitting right in the middle of it, and the Wi-Fi wasn't working, and I had to keep like re-logging in, which was a waste of time. So please make sure that you have a nice quiet room so you're relaxed and you're able to write. The thing is that we are out of practice. Most of us have finished PG maybe 1 or 2 years back, and it is very, very difficult to attempt a 100-mark paper with 10 questions. It's a lot of writing, and like I know it is funny to say, but your hand actually hurts. So please make sure that in the months leading up to the exam, you get some practice of writing. So I used to study with writing. I would make notes on upper limb, lower limb, and like if I wanted to talk about a specific block, I had like notes for it. So it gave me like some practice. So when I picked up a pen just before my exam, I was able to write. And most institutes do show the kindness of having a mock exam. So attempt the mock exam with the same vigor and the speed that you would write your actual theory exam, because that gives you an idea of your capability and how fast you can write. So please make sure that you just beautifully elaborate diagrams all over your paper, because it makes the correction easier for your examiners, because I used colored pens and very bold labels, because it makes your examiner want to read. And also especially like when you're talking about a lot of boring sentences, it doesn't really catch the eye and it doesn't really interest the examiner. So make sure that you have tables, that you have tabular columns with diagrams and very detailed labels. Every question, try to put some diagram in it to give you context, and it also makes your paper a pleasant read for the examiners. And lastly, timing is everything. It is a 100-mark paper. Each question is long, because this is a postdoctoral exam. You're supposed to be a specialist after this exam. So you need to know every single topic in minute and excruciatingly tiny details. So it will be long. You have 10 questions and you have 3 hours to write it. My strategy is I always do 15 minutes per question. And when I finish that 15 minutes, I drop the pen and I turn to the next question. And at the end, you'll get half an hour where you can come back and write all the extra things that you have left, because that way you will not leave any question unattempted. So remember that to pass this exam, you need at least 5 marks per question. So you have to have an attempt for each question. Otherwise, you won't be able to pass. So please make sure that you keep your timing very, very solid. And now coming to the practical exam. Okay, so this just a few, I have only 2 more slides. I'll just talk about practical exams. This is paramount. You need to ace your sonoanatomy and anatomy because everything comes down to that. So if someone asks you to pick out a muscle, a nerve, an artery, you should be able to say it, especially if that is the block that you're offering. So if I'm going to talk about supraclavicular block, I have to know each muscle, artery, nerve, everything in that area, because that will fetch you points, and also it will make sure that your examiner knows that you are well prepared. So your anatomy and your sonoanatomy has to be brilliant, and this only happens if you have done your volunteer scans. So please, if you have not had the time to do it and you are sitting and you're preparing for your theory, it is okay. But in those 1 or 2 weeks that you have between your theory and your practical, please make sure that you go back to your hospitals and you scan and scan and scan. So if someone says, show me the axillary block, you shouldn't stutter, you shouldn't fumble, you should be confident in this is the next point. When you are about to demonstrate that volunteer scan, there should be no hesitation, because that shows that you have done this. It is something that you are comfortable with. So the way you position yourself, the side that you stand on, the probe that you pick, the way that you know what is medial and lateral, and your ergonomics and the needle trajectory, all of it, it gives an idea to the examiner that this is something that you have comfortably done, and it is not something that you're just showing just for the sake of passing an exam. So this will only happen if you have done your volunteer scans. So in this 1 week between theory and practical, scan as many patients as you can. And it's very interesting because you'll also see, anatomical variations. You'll be able to impress your examiners by telling them, I've seen this, but this could also be there. And that gives you, an extra edge. And this is very, very important. I always say this to my PGs. The eye can see only what the mind has read and learnt. So if you are going to pass your practical exams, you have to have a solid theory base, because everything comes back to what you have read and what you have practiced. So this comes down to my last slide. The major part of your practical exam is the case discussion. So everyone's going to ask you, say for example, you'll get 2 cases. So maybe you'll get a forearm fracture and you'll get a knee surgery, something like that. So the first question that they're going to ask you is, how would you anesthetize this case? So before you attempt to answer this question, I want you to close your eyes and picture yourself in an OT alone. So you are the sole anesthetist, and this is the case that has come to you. You've got a case that has a forearm fracture. You know that it would be cool if you could very beautifully describe a costoclavicular block or an infraclavicular block, but it is also something that you have not done regularly, and it is not something that you would do for your patient. If I wasn't confident with a costoclavicular block, I would never touch a patient with that. What I know is axillary. So it's very important that the first plan that you offer as your choice of regional anesthesia strategy is something that you have done repeatedly, safely, and make sure that even if it is, like, say for example, you think that saying axillary block is basic or something that you have done in PG and it's too basic and it's too not thing, please do not keep that idea in your head and feel that you need to show off and need to impress by showing a fancier block. Do something, like demonstrate something that you have done, you will do as the anesthetist in that OT. So basic blocks are good, they are safe, and it is something that you have practiced well. And if you don't know a certain block, please do not offer it as your first line of management. So if you get a question, say I have like you get a question saying this is the knee surgery, the first plan A that you will offer for your answer is something that you know best, something that you would personally practice if you were the sole anesthetist in the theater, something that you have personally done 100 times, that you are very confident in demonstrating and answering, because like it comes down to the nitty-gritty, like the minute details. So like say for example, I'm very comfortable with, say, axillary block. Then I would know where to find the intercostobrachial nerve, where to find the medial cutaneous nerve of the arm, forearm, because it is something that I have done safely and multiple times. So it gives you an edge, and the examiner is very impressed when you talk about something that you have done and the small touches that you do as an anesthetist. So it is talking from personal experience, and it gives the examiner an idea that you once you finish this fellowship, you will go out and practice safely. And remember that the first plan that you offer is something that you can scan to perfection. So every minute artery, nerve, muscle, vein, everything that is there in the picture, you should be able to identify. So if after that the examiner says that, okay, fine, you did this, what else can you do? Then you can offer your plan B, your plan C, and all other options. Okay, so
Dr. Shruti,
yes, ma'am.
we are little short of time, and can we
I'm
wrap
done,
up
ma'am.
in
I'm
2
done, ma'am.
minutes?
This is the
Yeah.
last one, ma'am. Yes, ma'am. Okay. So that's it. That's just it. That is my advice to you all. All the very best. Please enjoy and study and pass your theory and practical exams, and we'll see you on the other side as faculty. Thank you so much.
Thank you, Dr. Shruti. It was really a wonderful and practical approach for the fellows' problems which we all face during exams. Thank you so much for sharing your insight. We
Thank you,
will
ma'am.
move ahead with today's first presentation, case discussion on THR, which will be done by Ritesh Roy sir and sir's fellow Dr. Aishwarya Solanki, which will focus on PENK versus CFI versus femoral and subpectineal obturator and LFCM. Welcome back, Dr. Ritesh sir.
Good evening, everyone. Welcome to the second RA Assembly. It's a very nice initiative of the Board of Studies, and I congratulate them for doing it every year. And so to start with the first topic of the day, it is on total hip replacement. And Dr. Aishwarya is going to present the case, then we'll go for a viva. Yeah, Aishwarya, over to you.
Excuse me, sorry to bother. Shweta, can we have the timer on, please?
Aage
Yes,
sir
the
ji,
timer will
namaste.
started.
Aishwarya, you can
Yes.
start.
I hope my screen is visible.
Yeah, it's visible.
Okay. So a very good evening to all the respected faculties and my dear fellow. So I'm Dr. Aishwarya Singh Solanki, an EORA Fellow of July 2025-26 batch at Care Hospitals, Bhubaneswar, under the mentorship of Dr. Ritesh sir. The topic for today's discussion is a case discussion on total hip replacement. So just a second. Yeah. So a 68-year-old patient named Mr. X, hailing from Cuttack, businessman by profession, came to the emergency room with alleged history of self-fall from bed on 28/10/2025 around 10 p.m. in the 10 a.m. in the noon. Chief complaints: excruciating pain near the left hip, unable to walk, and swelling in the left hip area. History of presenting illness. Patient was apparently normal 2 days back when he sustained an injury in his left hip after fall from his bed. He complains of excruciating pain which increases on slight movement and is not completely relieved on rest or with any painkillers. No history of loss of consciousness, bleeding or vomiting after the fall. No history of dizziness before the fall. No history of chest pain, palpitations, sweating. No history of stroke disorders, epilepsy. No history of thyroid disorder, TB, asthma, COPD, or any psychiatric illness. Medical history. He is a known case of hypertension since 10 years, well controlled on medication clinidipine and telmisartan. He is also a known case of type 2 diabetes mellitus since 8 years, which is poorly controlled and is on medication for the same, taking tablet glimepiride and metformin. There is no history of any known allergies, no history of any previous surgeries, and no history of any addiction. His general examination is as follows. He is thin build, moderately nourished, conscious, cooperative, and well oriented to time, place, and person. Patient is afebrile. His weight was 64 kg, height 164 cm, BMI comes to around 23.8. His BP was 138 by 90 millimeters of mercury, right hand in sitting posture. Pulse rate was 100 beats per minute, regular, no radial or radiofemoral delay. Saturation was 99% at room air. Respiratory rate 14 cycles per minute, regular, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. His metabolic equivalent score was more than 4 before the fall, and he had multiple bruises present over left hip. His airway examination, his mouth opening was more than 3 fingers, Malampatti grade 2, no loose or missing or artificial denture, thyromental distance was more than 6 centimeter, and neck and spine was normal. Systemic examination, central nervous system, higher mental functions were normal. His GCS score was 15 by 15. No sensory or motor deficit. Pain on movement of left limb was present. The cardiovascular system, S1, S2 present. No murmur was heard and no scar swelling or visible pulsation. His respiratory system, bilaterally normal vesicular breath sounds were present and no added sounds were there. Per abdomen was soft and non-tender. His drug history is as follows. He was taking tablet glimepiride 4 mg and metformin 1000 mg before breakfast, tablet clinidipine 10 mg and telmisartan 40 mg after food, and rosuvastatin 10 mg and ecosprin 75 in the night. His investigations were hemoglobin 13.9 gram per deciliter, platelet 3.38 lakh, PT 12.3, INR 1. His KFT, electrolytes, and LFT was within normal limits. His random blood sugars were 307 gram per deciliter, HbA1c was 8, urine ketones were negative. His ECG showed T inversion, lead 2 and V5. X-ray had increased bronchovascular markings, and echo had ejection fraction of 65%, with left ventricular diastolic dysfunction and mild TR. Diagnosis: a 68-year-old patient with hypertension and uncontrolled type 2 diabetes mellitus with neck of femur fracture, posted for total hip replacement.
Thank you, Aishwarya. So, Aishwarya, when you get these patients with a fractured neck of femur, so what is the aim of anesthesia management in these patients?
Sir, in such patient, our aim will be to preoperatively optimize the patient according to the standard protocols so that we can go ahead with the surgery within 36 to 48 hours. Then secondly, we will be remobilizing the patient by providing good analgesia and good hemodynamic stability. Then re-enabling the patient to resume the daily activities by day 2 to 5, and re-enablement, that is the long-term resumption of the normal activities.
Okay, so how are you going to prepare this patient preoperatively?
So in preoperatively, I'll do a thorough pre-anesthetic checkup of the patient with a detailed history and the airway examination. Then I'll optimize his blood sugars, and I will ask him to omit telmisartan on the day of surgery, and I'll shift the patient to calcium channel blockers like amlodipine. Then ecosprin will be continued perioperatively. Then I will ask him to omit oral hypoglycemic agents and insulin on the day of surgery. And I will explain the NPO guidelines, which will be 2 hours for clear liquid and 8 hours for solid food. Here, 8 hours because he is a patient of diabetic neuropathy, and in such patient, there is gastroparesis and delayed emptying. And I will advise him IV fluids. Then blood sugar will be done before shifting the patient to the OT. I'll request the patient for arranging the blood, and paracetamol and antacids will be provided as per the institutional protocol.
Suppose this patient would have been on warfarin. So what would it, how would you manage warfarin preoperatively?
So if the patient was on warfarin, then the first and the foremost, I'll stop the warfarin and send for an INR. Previously, after that, vitamin K 5 mg IV injection was given, and we used to wait for around 4 to 6 hours to repeat the INR. But according to the recent 2025 guidelines, if the patient is arriving in the ER with warfarin, we'll stop the warfarin, send for the INR, and if we have factor 4 prothrombin concentrate complex, that is PCC, then we will give it IV over the 10 minutes, and then we will repeat the INR. If INR is less than 1.5, we can go ahead with the surgery. But if the INR is more than 1.5, then we can again infuse factor 4 PCC. Along with that, I'll give the patient vitamin K injection 10 mg IV. Suppose I don't have factor 4 PCC, then if I have factor 3 prothrombin complex, then I will transfuse that over the 10 minutes, and again I'll repeat the INR. Again, if INR less than 1.5, I'll go ahead with the surgery. If not, I can again transfuse factor 3 PCC and vitamin K 10 mg IV. Here also I'll give the patient. Suppose I don't have factor 4 or factor 3 PCC, then in such scenarios, I will give 2 FFP. Then I will check the INR after 15 minutes. If INR is less than 1.5, again I'll go for surgery. But if it is more than 1.5, I can transfuse 2 more FFP to the patient. Then I will repeat the INR. And since we are giving 4 FFPs to reduce the volume overload, we can give loop diuretics to the patient also. And then I'll give vitamin K 10 mg IV to the patient.
So, what is the concept of what is the on-arrival block?
On arrival block is a block which is given in the emergency room as soon as the patient arrives before giving any other intervention. And the purpose of on arrival block is to provide pain relief to the patient.
So, what are the blocks which you can give as an on-arrival block?
As an on arrival block, I can give suprainguinal fascia iliaca block, or I can give a femoral nerve block, sir.
Okay. You told that you want to do the surgery within 36 to 48 hours, according to the guidelines, Griffith guidelines. So, what are the acceptable reasons where you can delay this surgery?
If the hemoglobin of the patient is less than 8, or if the sodium of the patient is more than 150 millimoles per liter or less than 120 millimoles per liter, if the potassium is less than 2.8 or more than 6 millimoles per liter, or if the patient has uncontrolled diabetes mellitus, or the patient has uncontrolled or acute onset of left ventricular failure, or if the patient has correctable cardiac arrhythmia with ventricular rate more than 120 beats per minute, if chest infection is present along with sepsis, or if there is any reversible coagulopathy, in such cases, I would delay the surgery.
Okay, now you have your patient is ready. It comes to the OR pre-op area. So, how are you going to go ahead with your intraoperative preparations?
Uh, Once the patient has come in the pre-op area, sir, I'll take the patient in the block room. I will check the IV of the patient, attach all the monitors. I will confirm the patient has given the consent, and I will check the side of the operation. Once I have checked all these things, I will give the patient the block for the positioning. So here in this, I will be using an ultrasound guided suprainguinal fascia iliaca block in which I will give 35 ml of 0.2% ropivacaine and 50 micrograms of dexmedetomidine as an additive. Then I will wait for at least 25 to 30 minutes for the block action to set in. Then I will wheel in the patient inside the OR. Once inside the OR, I will attach all the ASA standard monitors. I will flush the IV, and then I will position the patient for the spine scan. In the spine scan, I will be using a curvilinear probe. First, I will mark my parasagittal interlaminar oblique view. Then I will rotate the probe 90 degree and mark my interspinous view. Then I will combine both the points and mark it, keeping in mind the depth and the angle of my needle insertion. Then I will give spinal to the patient. In this, I will use 2.5 ml of 0.5% heavy bupivacaine with 15 micrograms of clonidine. And once I have given the spinal and the level is set, I will hand over the patient to the surgeon for the positioning. Then I will also give the patient antibiotic, making sure it is given before the incision is made. And I'll give tranexamic acid 1 gram IV and dexamethasone 8 mg IV according to our institution protocol. And since the patient is diabetic, I will do an blood sugar monitoring intraoperatively also.
So you told that you will be giving a sci-fi block for positioning. So can you give any other block for positioning apart from sci-fi? Any other options?
Yes, sir. For the positioning, we can give femoral nerve block also, sir.
Any other block?
And we can give PENG also.
Okay. So what are the structures you cross during spinal by a midline approach?
If we are going by the midline approach, I'll be piercing the skin, subcutaneous tissue, the supraspinous ligament, interspinous ligament, then the ligamentum flavum. As I cross the ligamentum flavum, I'll reach the epidural space, and then I'll cross the dura to reach the subarachnoid space.
Okay, so you gave a sci-fi block for positioning. Was this block also for your post-op analgesia?
Yes, sir.
So, what is the innovation of the hip joint?
So coming to the dermatome first, the most common incision used is the posterolateral incision for the total hip replacement surgeries, and even in our institution we use that. So the dermatome, according to that, will be the lateral femoral cutaneous nerve, the lateral branch of the iliohypogastric, and if we go further behind, it will be subcostal, and then more posteriorly, it will be superior cluneal nerves. Then coming to the myotome, it will be by the femoral nerve and the superior and inferior gluteal nerves. And the osteotome, we have anterior capsule and the posterior capsule. So the anterior capsule of the knee has the maximum nociceptors, and it is supplied by the articular branches of the femoral nerve, obturator and the accessory obturator nerve. And the posterior capsule has supply from the sacral plexus, like the sciatic nerve, the nerve to quadratus femoris, and the superior and the inferior gluteal nerve. And also, talking about the labrum, that also has nociceptors whose density decreases radially from periphery to the central. And then there is ligamentum teres, which has high density of nociceptors in the center and it decreases towards the side. Then also we have transverse ligament, which has both nociceptors and the mechanoceptors. Then coming to the three extrinsic ligaments we have, that is the iliofemoral, ischiofemoral, and the pubofemoral ligaments. They have a moderate density of mechanoceptors, but there are no nociceptors in them.
Can you do the surgery solely under blocks, not neuroaxial, solely under blocks?
Yes, sir, we can do this under a lumbosacral plexus block.
So, what's the technique of lumbosacral plexus block which you follow?
We use dual guidance, sir, for performing the lumbosacral plexus block, that is ultrasound and the PNS.
So, what is the end motor response you will take for a lumbar plexus block? What is the
Uh,
end motor response at what current?
at 0.5 milliamperes or above, we'll be looking for the quadriceps contraction, sir, if we are doing the lumbar plexus block.
So, suppose you are having a contraction below 0. Suppose even at 0.5 you are getting a quadriceps contraction. What are you going to do it? What it signifies?
It signifies, sir, that we might be in the dural sheet of the nerve. So I will pull back my needle and then check
Uh,
for the contractions.
and what is the end motor response for the sacral plexus?
For the sacral plexus, we'll see the contractions of the muscles of the posterior aspect of the thigh and the calf and the foot, and the best response will be eversion of the foot.
Okay. What are the blocks for analgesia? Solely analgesia.
So for the analgesia, we can give epidural catheters. Then we can give lumbosacral plexus block along with the local infiltration of the incision site. We can go with anterior quadratus lumborum. Then we can give lumbar adductor spiny block. We can also give femoral nerve block along with lateral femoral cutaneous nerve or suprainguinal fascia iliaca block or the pericapsular nerve group block along with lateral femoral cutaneous nerve or an iliopsoas plane block.
Uh, what is the block you practice maximum for a post-op analgesia?
So we practice uh, PENG with LFCN or a suprainguinal fascial iliaca block.
So, what is a pain block?
PENG is a facial plane block in which we are depositing the drug in a periosteal plane between the psoas tendon and the iliopubic eminence, where we are catering to the articular branches of the femoral nerve, obturator, and the accessory obturator nerve.
So, what are the tips for a safe needling? What are the structures you have to take care when you are putting the needle while placing the needle in a pen block?
So first and foremost, before giving a PENG block, scout scan is very important so that we can identify where my lateral femoral cutaneous nerve is, where my femoral nerve, or sometimes the circumflex arteries are there. So once we have identified by the scout scan, so we can pre-plan our needle trajectory. And while giving local anesthesia, like the local when we are giving, we should notice if the patient is complaining of any lateral thigh tingling. This means that we might be hitting the lateral femoral cutaneous nerve. Then we should inject, a needle tip should be lateral to the psoas tendon, and we should not use maximum dose, like the maximum effective dose is 13.2 ml. So we should not go more than 15 ml. And then we should avoid any high volume and high concentration, and also should avoid injecting with high pressure. So that
So what is the what signifies that the drug is deposited in the right plane? How can you confirm it? What you want to see when you are injecting the drug?
when we are injecting the drug, sir, we can see the lifting of the psoas tendon, and we should we should be the drug should not go towards the medial side of the psoas tendon, and the drug should be confined to the lateral side of the psoas tendon only.
So is it it has been called that PENG is a motor sparing block. Is it motor sparing?
According to some of the previous literatures, they have claimed that the pen is a motor sparing block. But some recent articles have quoted that up to 0 to 45% of the cases, pen is not a motor sparing block.
So as you have told, how can you make it? What precautions you are going to take so that you don't you can make it as a motor sparing option?
So, sir, for that, we should make sure our needle tip is lateral to the psoas tendon, and we should use low volume, like the maximum effective volume is 13.2, and low concentration. And most important, when we are injecting the drug, we should do in a small liquids and not with much pressure, because it could lead to bursting of the iliopectineal bursa. And once it bursts, then the local anesthetic can go to femoral nerve.
So what is a sci-fi block?
Sir, it is also a facial plane block, which is in which we deposit the local anesthetic suprainguinally between the fascia iliaca and the epimysium of the iliacus muscle to block the femoral nerve and the lateral femoral cutaneous nerve.
So what are the ultrasound landmarks to identify the correct place of depositing the performing the sci-fi block?
Yes, sir. So for the sci-fi block, firstly, we'll be using a linear probe. We will keep the probe at the anterior superior, middle to the anterior superior iliac spine in the parasagittal oblique view. Then we'll try to identify the iliacus muscle, below which there will be anterior inferior iliac spine. So there will be above will be the iliacus muscle, and on the medial side we'll have the internal oblique muscle, and on the lateral side we'll have the sartorius. And this sartorius and the internal oblique
Me,
will be forming
me,
a bow tie.
medial lateral or cephalad caudal? You are getting
Cephalad
confused.
quadrant, yes, sir. Uh,
Okay.
the cephalad will be my internal oblique, and the quadrant will be my sartorius, and this will form a bow tie appearance. And the most important landmark here we need to identify is the deep circumflex iliac artery. This DCIA sits above the fascia iliaca, and our plane is below the fascia iliaca and above the epimysium of the iliacus. So when we are injecting, firstly, it requires a large volume of drug, and when we are injecting, they will be zipping open of the plane, and we should make sure that our drug is not deposited around the deep circumflex iliac artery. If it is present, it means we are in the wrong plane.
Is obturator nerve blocked in suprainguinal fossa iliaca block?
So there have been studies which says that 0 to like up to 20% cases obturator nerve is blocked, but there was a cadaveric study done by Werner et al. And review article by Thomas et al. In which they have said that the obturator nerve lies in a retropsoas compartment, and via the obturator canal it goes into the retroperitoneal compartment. Then secondly, the fascia iliaca splits and it encompasses the external iliac artery, and obturator nerve lies below this external iliac artery, and our femoral nerve and lateral femoral cutaneous nerve lies above it. And also, fascia iliaca is a very compact compartment, so there is no direct communication to the obturator nerve. Hence, majority of the cases it's not blocked.
So what is the difference in the analgesia quality between the PENG and the sci-fi block?
So, according to an article, by systemic review and meta-analysis by Jinhu et al. When comparing the static pain management and 24-hour opioid consumption, the sci-fi and Peng were equivalent, but Peng was better than sci-fi for dynamic pain control. Also, it was better for early ambulation in the patients, and also it provided low quadratus weakness incidence. Hence, in the ERAS protocol, Peng is preferred.
Okay. Uh, so how do you assess the quadriceps strength in the post-op period?
So for the quadricep weakness assessment, sir, either we can do a tug test. In tug test, we'll ask the patient to flex the knee and ask him to tug the patella so we can see the quadriceps contractions. Or we can do the punt test, in which we'll ask the patient to flex the knee and the hip and ask him to push against resistance. So if he's able to do, means he doesn't have quadricep weakness. Or if possible, we can use a dynamometer.
Suppose your patient has an INR of 1.8 or 1.9. So what are your analgesia block options?
So if the patient has INR 1.8, so we won't go for deep blocks. So we can go for the superficial blocks, like we can give a lumbar erector spiny plane block, or we can go ahead with a suprainguinal facial iliaca block, or a femoral nerve block with lateral femoral cutaneous nerve. We'll surely avoid the central neuraxial blocks and deep blocks.
So what is the prospect guideline for THR?
So the recent most prospect guidelines for the THR says that we should use paracetamol along with NSAIDs or COX-2 inhibitors for multimodal analgesia perioperatively, and opioid should be used as a rescue analgesia, and a single shot femoral nerve block or a single shot fascia iliaca compartment block should be given, and no catheter should be used except in specific conditions, and the choice of spinal anesthesia or a general anesthesia will depend on the factors other than the pain.
Now people are talking about posterior hip pain. Is it a fact or a myth? And how can we control it?
So, posterior capsule generally has mechanoreceptors, but there are some silent nociceptors which will get activated in any pathological conditions. So to cater to that, we have two blocks. One is the posterior pericapsular deep gluteal block, and the second is the posterior hip pericapsular block, which is a modification of the sacral plexus block. And these two blocks can be used to cover the pain from the posterior capsule.
So what do you do in your institution?
So in my institution, we manage the posterior capsule block with a multimodal analgesia.
Okay. Now your patient was uncontrolled diabetes. So is there any special precautions you are going to take before performing a nerve block?
Yes, sir. Since the patient has uncontrolled diabetes, there are chances of diabetic neuropathy. So first and foremost, it is very important that we document if there is any diabetic neuropathy. Then, if we are using a PNS, then the requirement of the current will be more in such patients. And for the local anesthetic, we should decrease the dose of the local anesthetics because the nerves in such patients are very susceptible to the local anesthetics, and also the blood flow in these nerves are reduced. So there will be a prolonged block, and we should avoid use of any vasoconstrictors in the local anesthetic because it can lead to further damage of the nerves. And since these patients are prone to infections, so all the blocks should be done under strict aseptic guidelines.
Okay. So what are the post-op advice you are going to give to these patients?
So, in the post-op period, once the surgery is over, I'll shift my patient to the intensive care unit. Then there will be round-the-clock sugar monitoring since he had uncontrolled diabetes. Then I will start the patient's oral hypoglycemic agents or insulin once the patient's diabetic diet starts. And I will resume his antihypertensive medications as it was preoperatively advised. Then I'll give 0.4 Clexane 0.4 subcutaneously after 6 to 8 hours of the surgery. Then for analgesia, I'll be giving paracetamol or in such and tramadol and the diclofenac. Then I'll try to mobilize my patient early with support. And on the post-op day 1, I'll send for CBC and kidney function test. And if my reports are within normal limits, I'll shift the patient to the ward.
Okay. Thank you, Aishwarya. That was a nice session.
Thank
Thank you. Thank you, Sangamitra.
Yes, thank you. Thank you, Ritesh and Dr. Aishwarya. Wonderful demonstration, mentor-mentee. Congratulations to both of you.
Thank you.
Yeah, so we'll move on to our next session, and that is Dr. Sumita Christopher, and so we have awake proximal humerus surgery. Over to Dr. Sumita.
Yeah, good evening all. Can you hear me?
Yes, yes, we can hear you.
Yeah, it's on.
Yeah, so both of us are logging from the same place. So the case discussion today is on proximal humerus surgery, which can be very challenging as there is no single anesthesia technique that can block this area. So we'll be discussing this case, and Dr. Shushmita is going to share her slide, and we're going to start the case discussion.
Good evening, everyone. My topic for today is awake proximal humerus fracture surgery. I'm Dr. Sushmita, and my moderator for today is Dr. Somita. She is the senior consultant at Care Group of Hospitals, Hyderabad. So my patient is a 68-year-old female with she's a resident of Hyderabad with who came to me with alleged history of fall from bike, following which she complains of intense pain in her right shoulder and inability to lift her arm. There is no history of head injury, loss of consciousness, or any ENT bleed, no chest or abdominal injury, and no history suggestive of any seizures or dizziness before the fall. In her past history, she is a hypertensive and a diabetic since 25 years. She is on tablet telmisartan 40 mg once a day and tablet clinidipine 10 mg twice a day. For diabetes, she takes tablet glimepiride and metformin 2 mg and 500 mg BD. She is also dyslipidemic and she is on tablet Ecosprin AV 75 mg OD. My patient is obese with a BMI of 32 kg per meter square with an obstructive sleep apnea on home oxygen therapy since 9 years. She has been admitted 4 times in the past for COPD exacerbations, and she has undergone 2 cesarean sections 40 years ago under spinal anesthesia. Both of them were uneventful. In her personal history, the bowel and bladder habits are normal, but she has sleep disturbances with regular daytime somnolence. In examination part, general examination.
Sushmita, before you go to examination, can you just tell me what are the important points as far as the history is concerned for this patient?
My patient is a geriatric patient, elderly female. She is known hypertensive, diabetic, also obese, with a sequelae of OSA and requiring home oxygen therapy.
You said there is no history of any chest injuries or any fractured ribs. Why is it important to ask in this patient, especially for the patient who comes with a proximal humerus fracture?
Yeah, so because my anesthesia management would actually depend on that, because since it's a proximal humerus fracture surgery and my gold standard for such surgeries is interscalene brachial plexus block, I would want to see whether there is any respiratory compromise or no.
Okay. Any other positive history? Okay. What about the examination?
Yeah. So my patient is obese, and her on airway examination, she has 3 finger breadth inter-incisor gap with a short neck with a neck circumference of about 40 centimeters. Malampati class grading is class 3. She has an anticipated difficult mask holding and intubation, but she had no pallor, cyanosis, citrus, or clubbing. On local examination, there's swelling over the right shoulder with painful restricted abduction, but there was no evidence of any local infection. Also, she had active finger movements and sensations below her elbow. On systemic examination, rest of the systems were fine. On respiratory system, chest auscultation was clear, but her breath holding time was less than 10 seconds. Coming to the vitals, patient was afebrile, her pulse rate was 86 per minute and regular, blood pressure was 140 by 80 millimeter of mercury, saturation was 92% on room air with a respiratory rate of 22 per minute. Some investigations were advised, complete blood count, serum electrolyte, PTINR, all of them were normal, even serum electrolyte was normal. Sugars were on the higher side with HbA1c of 7.8. Chest X-ray showed increased bronchovascular markings with COPD changes. On ECG, there was left bundle branch block changes, but on 2D echo, she had preserved left ventricular function.
Okay, so this patient was posted for surgery, right?
Yeah, she was posted.
What was the surgery plan for this lady?
The surgeons has planned an open reduction in internal fixation with a Philos plating, and their incision was supposed to be deltopectoral.
So this patient was admitted one day prior to surgery at the hospital, I suppose?
Yeah.
So how did you optimize this patient for the surgery? So because you said this patient is on CPAP.
Yeah.
No case of COPD on CPAP.
Yes,
So how did you optimize this lady prior to the surgery?
Yes. So on discussion with the surgeon regarding the patient's condition, we advised the patient to get admitted one day prior to the hospital. She was asked to get her BiPAP machine from home, and the same was continued on the previous night. And in the morning, an arterial blood gas was sent for to look at the level of hypoxemia the patient had. Apart from that, the patient was counseled. She was told regarding the options she's got with respect to anesthesia. She was explained all the benefits and the
what specific things you told the patient, because you're planning to do this patient under regional
anesthesia.
So what are the specific things you told this patient about as far as the block is concerned?
Yeah, so first and foremost, I told her how high risk general anesthesia would be for her, with respect to her poor respiratory compromise. I told her whatever regional anesthesia options we've got. I told her that the patient she will be awake during the surgery, and that she will have to receive 2 or 3 injections near her neck region, and we can, if she requires, we can give her minimal sedation, but more than that is harmful for her health. And all of that was explained, not just to her, but also her attendants.
Okay, so what was the plan of anesthesia for this patient?
So my plan A for this patient is a ultrasound guided supraclavicular and upper trunk block with that's it.
Okay, so how did you do the block? What were the ergonomics, and how did you go about giving this block?
So once consent was checked and her fasting was confirmed.
The plan was to give a supraclavicular and upper trunk block, which is also known as the scud block. Yeah, go ahead.
Yeah, so once her fasting status was confirmed, we wheeled her into the operation theater. ASA standard monitoring was started. Oxygen was anyways going on. So since it is a right-sided surgery, I was standing on the right side of the patient with the ultrasound machine to the left of the patient. I used a high-frequency linear probe, and I placed it over the supraclavicular fossa. I identified the subclavian artery and the vein and the brachial plexus, which are present posterior lateral to it. Once that was done, so we followed the sequential ultrasound imaging technique. Once this was seen, I moved the probe cranially to identify the individual roots. So from C2 to C5, the transverse processes have equal anterior and posterior tubercles. So in the USG, it looks as a U-shaped shadow. So the C5 root can be identified this way. When it comes to C6, there is a prominent anterior tubercle, and for C7, there's an absent anterior tubercle. So also with the vertebral artery in front of it. So once the C5, C6, and the C7 are identified, I would move my probe caudally to see when the C5 and the C6 merge to form the superior trunk. Of note over here that I will make sure is to always put a color Doppler in the view that I'm getting, because it's very common to find the transverse cervical artery or the dorsal scapular artery, moving around it. So we have to make sure that during needling, where that doesn't come in the way.
What is another important point you have to keep in mind when you're calling it a superior trunk?
Yeah, so since looking at the innervation and whatever I require for the shoulder joint, my suprascapular nerve needs to be blocked in this patient. So I have to make sure that the suprascapular nerve has not branched out from the superior trunk while I'm giving the block.
And how was the needle inserted?
So I usually prefer needling from in plane. Needling in plane from the lateral to the medial side.
So, what needle did you use?
For this case, I used a 50 millimeter needle, and once I reached the superior trunk, I deposited around 0.375% of bupivacaine, which is what we do in, an institution.
And how much volume of the drug did you use?
We gave just about 10 ml was enough.
Okay.
Yeah.
And what about the supraclavicular? You said you're going to combine it with the supraclavicular nerve block.
I would try to in the same needle prick, I would try to move my probe to the lateral edge of the sternocleidomastoid and deposit around 5 ml of the drug underneath it. If that is not possible, then maybe another needle prick.
So the total volume of the drug which was given was
10 ml plus 5 ml, 15 ml.
Okay, so to perform any block in the shoulder region, you first need to know the innervation of the region. So, what do you think is the innervation of the proximal humerus with the shoulder?
Around the shoulder joint, so basically the shoulder joint receives innervation from both the cervical as well as the brachial plexus. So the supraclavicular nerves, they give you cutaneous innervation to the skin above the clavicle and to the tip of the shoulder. And from the brachial plexus to the anterior side, we have mainly innervation from the axillary nerve, the subscapular nerve. We also get innervation from the lateral pectoral nerve and sometimes the musculocutaneous nerve, whereas the superior part and the posterior part of the shoulder is mainly supplied by the suprascapular and the axillary nerve. Coming to the osteotomes, from the C5 you have the deltoid, the supraspinatus, the infraspinatus, and C6 gives the innervates the biceps brachii, the brachialis muscles, and subscapularis also. When it comes to osteotomes, it mainly gets innervation by the suprascapular, subscapular, and the axillary nerves.
Okay, so this incision was going to be deltopectoral.
Yeah.
So if the incision goes a bit medial, do you think you need to block anything else?
Yes. Ideally keeping in mind that so for this incision, this block is enough. But in case the surgeon ends up extending the incision more inferiorly or medially, then we will have to block the intercostobrachial nerve, which gives innervation to the medial aspect of the upper arm as well. So either we can do that before the surgery starts, or we can even ask the surgeon to infiltrate local anesthetic before extending his incision.
So by giving a scud block, you're actually giving a phrenic nerve or a diaphragmatic sparing block.
Yeah.
Right?
Yeah.
So how much time did your block take to set?
So usually, ideally, I would like to wait for 30 minutes before assessing my block because we're giving around 0.375% of bupivacaine, but practically that is not how much time we get to assess it. I'll wait for 10-15 minutes and then I will assess my block.
So how was that done? How did you assess your block?
We usually take a cold spirit swab and look for the, see whether the dermatomes have lost their cold temperature sensations. And since the joint was extremely painful before the block to my patient, I would confirm with the patient whether she has received, she has been relieved of the pain or not. Also, I will ask her to abduct the shoulder, and any inability of doing so will confirm my motor blockage.
So, Sushmita, but we know that the interscalene brachial plexus block is a gold standard for these surgeries.
Yes.
So, why did you not do this and you have come down and performed a scud block for this patient?
Yeah. So, yes, interscalene brachial plexus block is the gold standard for any proximal humerus fracture surgery. But it also comes with a sequelae of 100%, almost 100% of phrenic nerve blockade. In my patient who is already having obstructive sleep apnea, is requiring BiPAP and home oxygen therapy, her respiratory reserves are already on the lower side. So any phrenic nerve compromise can decompensate my patient. So this is the reason I did not go for an interscalene brachial plexus block. So having said that, if you look at the anatomy of the phrenic nerve, at the level of C5 root, it is around 1.5, 1.8 to 2 centimeters away from the C5 root. But as it keeps coming keeps coming caudally, the distance increases by around 2 millimeter every centimeter. So the more distal you give the block, the less chances there are that you are blocking the phrenic nerve. Also, initially for interscalene brachial plexus block, they used to use a lot of volume. So with the advent of ultrasonography, we can, as we have done in our case successfully, we've given as less as 10 ml. So the chances of it blocking the phrenic nerve are much less than the traditional way. But having said that, any block which is done above the clavicle for brachial plexus does have a chance of phrenic nerve blockage.
So that means even if you have given a scud block, it also has chances of phrenic nerve blockage.
Yes.
So what is the percentage for scud block?
Oh, it's as less as 4%, but it goes till up to 35%.
So this is your patient who was a COPD, and anyways her diaphragm was not much contributing to her tidal volume.
Yeah.
So let me just take you to another scenario, that is, say, a case B, in which you have a patient who is really obese. He has a very restricted, hardly any leg, restricted mouth activity, and 100% it requires a phrenic nerve sparing block. So what are your other options for doing this particular case?
Since I'm looking at anesthesia part of it, for completely 100% sparing blockade, there are options where people give infraclavicular brachial plexus block, and then they will have to supplement it with suprascapular nerve block. I think this is.
So why would you choose an infraclavicular brachial plexus block?
Because again, like an intraclavicular.
So what are the various nerves branches which are supplying the shoulder over there?
Yeah, so the axillary nerve, the subscapular nerve, both come from the posterior cord. The lateral pectoral nerve is coming from the lateral cord, and musculocutaneous nerve sometimes. So apart from the suprascapular nerve, I think everything else gets covered in the infraclavicular. And since the suprascapular is branching out much higher up in the neck, we will have to block it. And if I really require 100% of phrenic nerve blockade, then I can block the suprascapular nerve even in the posterior, in the supraspinous fossa.
What is the way to block the suprascapular nerve anteriorly?
So anteriorly, the same scan that I described before, once I locate the superior trunk, I just have to see the suprascapular nerve branch out from the superior trunk and move below the omohyoid muscle, which is usually seen as a hypoechoic muscle, hypoechoic structure. So once I find once I can trace the suprascapular nerve underneath that muscle, I can deposit around 5 to 6 ml of drug there.
Okay, what about the posterior approach to suprascapular? How is that performed?
Yes, so for that, I will have my patient in the sitting position. The same high frequency linear probe can be kept over the scapula in the supraspinous fossa. So in that fossa, first what you see is your supraspinatus muscle, and between that and the scapula, the bone surface, you can see the suprascapular notch, and in this notch, the nerve as well as its vessels are present.
Okay, so coming back to your case, so the what is going to be the position of the patient for this surgery?
My patient is going to be in the supine position with a slight head elevation, which is, the most comfortable for it.
Okay, are you going to give any sedation to this patient?
Ideally, if the patient is not really requiring it, I may not. Also, I will definitely talk to the surgeons and the OT staff regarding this, telling them that, we are planning the surgery and keeping the patient, giving awake and like regional anesthesia with patient being awake. So this will, it just keeps this, there's no, people don't make a lot of noise. The surgeons watch before, whatever they're discussing, something unpleasant in front of the patient. Also, the sisters will not use the patient's rest of the body to keep things or put some pressure while standing. All of these are very important. Also, I will take care of the fluid that I give to the patient because full bladder is usually very discomforting to the patient. Having said that, if the patient is requesting for some sedation, I can start some maintenance dose of dexmedetomidine for this patient. Sometimes, if sometimes low dose opioids also we've given around 50 micrograms of fentanyl also we've given.
So, surgery is going on well, incision has been done, but half an hour into the surgery, the patient starts complaining of a mild breathing difficulty. So, what will be your next step?
Okay, so since I know that I'm performing a brachial plexus block about the clavicular, my first guess would be a phrenic nerve blockade. So I would want to actually look at that. But before that, of course, look at the vitals of the patient. I will see whether the saturation is being maintained or any supplement, oxygen supply needs to be increased or she's requiring any positive ventilation. If not, so once that is settled, I would like to scan. Since I have a ultrasound machine right next to me, I would like to scan for diaphragmatic excursions. Also, I have not done a pre-op scan in this patient.
Yeah, so that can only be done if you have done a pre-block scan.
Yes,
Then only you can compare the post-block. If anything,
Correct.
something like that happens, you can compare the
Correct,
exercise. What are
correct.
the other things you can assess the phrenic nerve blockade? You can ask the patient to do something.
I can ask the patient to sniff. So ideally, when you ask the patient to sniff, it's like
Rapidly sniff.
rapidly sniff. You can see the slopes if the diaphragm
Upward.
if that. If there is no phrenic nerve palsy and all, you will see good upward and downward movements of the diaphragm. But if that is not there, then I can probably think of it. There is a certain scoring where they say that more than 75% of decrease in the diaphragmatic excursion tells you that it's a complete phrenic nerve blockade. Between 25 and 75%, it's a partial phrenic nerve blockade, and less than 25, there is no paralysis.
So do we need to, aggressively treat all the breathing difficulties or phrenic nerve involvements which are there, or it depends on the patients?
It depends upon the patients. Usually, a young patient or a patient whose there is no respiratory compromise, usually they do tolerate even partial paralysis of the diaphragm. It's only in the very severe paralysis and if the patient is decompensating that you need to intervene.
Okay, so till now, what we were discussing were all the blocks for surgical anesthesia. Now, do we also have blocks as far as this procedure is concerned for analgesia?
Yes. In case not just this patient, any patient, if the patient is not consenting for a sole regional anesthesia technique, I might give general anesthesia to the patient, and in such patients to take care of the post-operative analgesia and reduce my opioid requirements, I will like to give isolated suprascapular and axillary nerve block. That can be done. The same scud block that I have performed, that can also be given in analgesic doses. And there are certain blocks that are only for analgesia.
So before you do that, how do you perform a isolated axillary nerve block?
So the axillary nerve isolated can be blocked in the posterior part of the patient's arm. The patient can be made sitting and or in the lateral position. You can, we keep the high frequency linear probe between the humerus and your posterior axillary fold. And there, basically, you're looking into the quadrangular space where the axillary nerve is present with the posterior circumflex humeral artery. So in the sonography picture, it looks you see the deltoid, you see the teres minor, and there you see the axillary nerve with the posterior circumflex humeral artery pulsations.
Okay, what are the other neuroanalytic blocks which have been described for the shoulder?
Yeah, so there are articles on people being being these blocks being practiced, though I have never seen them. uh, there is something called a shoulder peng block. So there basically they are depositing the drug between the deltoid muscle and the subscapular wrist tendon. And um, it is similar to the hip peng block. So it kind of gives it is an analgesic block and motor sparing. So that can be used. There are certain articles where they say that cervical ESP has been tried for the same. And also there is an article where it says there is something called as intraspinatus teres minor plane block. So yeah, these I think, yeah.
So apart from phrenic nerve involvement, do you anticipate any more complications in these patients?
Yeah, there can be recurrent laryngeal nerve injury. There can be Horner syndrome where patient can have ptosis, meiosis, and hydrosis. There can be any vascular injury since the neck is such a vascular structure, so patient can have an hematoma formation. If we happen to deposit the drugs very close to the roots, there can be a spinal or an epidural spread. Um, Apart from this, yeah, since you said respiratory distress, my patient is obese and everything, the patient can also have a pulmonary thromboembolism sometimes, but yeah, usually they're very
Okay, coming
far-fetched.
back to the interscalene block, which has been now given with very low doses and increased concentration.
Yeah.
What are the various precautions you will take while giving this block?
Yeah, so one thing, like I said, I will put Doppler whenever, like I have this practice of putting color Doppler whenever before giving the block, because the neck is a very vascular structure, and around the superior trunk you can expect to see the dorsal scapular artery or the transverse cervical artery, and you do not want to,
So your needle
pre-occlude
is going to pass specifically to the middle scalene muscle.
Yes,
yeah?
yes.
So anything,
So there are two
anything you
nerves.
want to keep in mind?
Yes, so there are two nerves which pass through the substance of the middle scalene. These are the long thoracic and the dorsal scapular nerves. So either if we do have an available PNS peripheral nerve stimulator with us, it is always recommended to use that and go ahead so that we will know whenever we are traversing the nerve.
So your patient was only on ecosprin and a torvastatin combination. So if this patient was also on clopidogrel, and which was stopped only a day prior, that is the day she had a fall, would you go ahead doing this block, or you'll tell your surgeon to wait?
So ideally, so depending upon how emergent or urgent the surgery is, I think that would decide. Since I feel the discuss with the surgeons. I will tell them that since the patient is on clopidogrel, the ideal way is to wait for 5 to 7 days when you stop it, and then we go ahead with blocks. But in case the surgeon is not willing to wait for such a long time, even say 3 days into stopping the drug, we have given these blocks because they are superficial blocks, and we can go ahead with them. But yeah, definitely any neuraxial blockade or deeper blocks would be contraindicated.
Okay, the block you have given with 15 ml of drug is going to last, say, for 18 hours. But these patients are usually immobilized for 3 to 4 days. The surgeons don't want their patients to move their hands. So is there any way you can prolong the analgesia for these patients? In other words, do you have
Dr.
any
Somita ma'am,
additives? Yes.
thank you so much. Sorry for interrupting. We are a bit short of time.
Yeah,
So
we are done. This was my last question. So, do you
okay,
add
ma'am.
any additives to the drugs?
Yeah, so in my institution, there is no, we don't have a protocol of adding any additives directly into the local anesthetic solution. But yeah, we do practice giving IV dexamethasone 8 mg for the same.
Okay. Right. Thank you, Dr. Sangamitra. I'm done over here. Thank you
Thank you,
very
ma'am.
much.
It was a wonderful presentation, especially the discussion on how to take care of patient under regional anesthesia, the sister keeping things and all. So thank you so much. Moving ahead, we will move to Dr. Pandya sir's fellow. Dr. D. Karthik Chari will talk today about LSCS and management of labor analgesia and post LSCS analgesia management strategies. Good evening and welcome, Dr. Pandya sir. Pandya sir, you need to unmute yourself.
I have unmuted.
Thank you,
Is
sir.
the screen visible? Hello.
Not yet, sir.
Is the screen visible? Screen is visible?
Now it's visible.
Yes, now it's visible.
Yeah.
Thank you.
Good evening, all. Congratulations, Evara, for this fantastic year, second year in consecutive with this fellowship training sessions before the exam. Without wasting much time, let me go straight to the case. Dr. Karthik, are you available online?
Yes, sir, I'm available.
So we have got two
I hope
interesting
I'm audible.
two interesting case scenarios that we had in the recent past in our hospital. There is a case who is a 28-year-old Mrs. S, primary gravida, 39 weeks, unbooked case. She came with history of preeclampsia without severe features. She was on labetalol 100 mg twice daily and nifedipine 10 mg twice daily. The preeclampsia profile, I'll come to it a little later, but morbidly obese, parturient, anxious, exhausted, request for pain relief. So, Karthik, I would like to explain briefly before we go into the actual procedural details, a brief mention about the effect of labor pain on the various organ systems and what are the implications specifically in patients with preeclampsia, which is one of the commonest medical disorder.
Sure, sir. So before we plan any strategy for the labor analgesia, I would like to step back and understand what labor pain actually does to the mother, physiologically. And in a patient with preeclampsia especially, these changes are far more exaggerated and they're very dangerous for the patient. For example, if you come to the cardiovascular system, the labor pain increases the sympathetic outflow. This sets in tachycardia, hypertension. There is an increase in the stroke volume and cardiac output. And also the systemic and the pulmonary vascular resistance is at rise. All of this increases the myocardial oxygen demand. And because my patient is already a preeclamptic, she already has vasoconstricted state and a high systemic vascular resistance. So labor pain will push her BP even higher, increasing the risk of intracranial bleeds, placental hypoperfusion, and myocardial stress. This is where we emphasize on labor analgesia because this will physiologically protect the patient from these adverse side effects and also providing good labor analgesia and providing her with a good labor experience. Coming to the respiratory system, due to the pain and anxiety, the mother will hyperventilate. And during the sessions of in between the contractions, she can experience some hypoventilation and apnea episodes. The net effect in the respiratory system is the respiratory alkalosis. This will cause a leftward shift of the maternal oxyhemoglobin dissociation curve and making the oxygen unloading to the fetus more difficult. And there are a few metabolic changes also in the mother. There is persistent pain. This results in massive catecholamine release. This drives the maternal metabolic acidosis during long sustained contractions, and the body tries to compensate it with respiratory alkalosis, creating mixed acid-base disturbances. And the effect is not only on the mother, it is also there on the fetus. There can be decreased uteroplacental perfusion because there is no autoregulation in the fetus yet. There is fetal hypoxemia, fetal acidosis. This explains why a poorly controlled labor pain can indirectly affect even the fetus along with the mother. Sir, like you asked,
Thank you.
there
Yeah.
are certain specific implications for preeclampsia. For example, like the platelets and coagulation. The preeclamptic mothers have thrombocytopenia, dysfunctional platelets. So we definitely have neuraxial considerations regarding the hematomas concerning the platelets. There is endothelial dysfunction. There is a capillary leakage. So there is an increased incidence of pulmonary edema during intraoperative or postoperative period. And
Okay.
also, usually pregnant women have edema, airway edema, but it is again exaggerated in the preeclamptic patient.
So basically, this lady was on 9 on 10, and as I said earlier, she is exhausted. She's 2 to 3 centimeters dilated, and she's requesting for pain relief. Alternate non-neuraxial options have been tried, but she's not comfortable. And the preeclampsia profile that was sent just about 2 hours back has come back with this report, like platelets of 78,000 and borderline elevated ASTs, ALTs, and LDH. So, yes, what are your options? What option do you have now?
So actually, speaking of VAS, what you told is a subjective score. I would like to obtain an objective score before choosing my technique. So objective score, I would select by using the physiological indicators like how much tachycardia is the patient have? Is there any raise in the blood pressure map, or is he tachypneic? And I would like to keenly look at the CTG also, cardiotocogram or a tocodynometer findings which will tell me the correlation between the uterine contraction and the pain correlation of the patient. Because simply having a VAS score of 9 or 10 doesn't mean that the patient is having a painful contraction. So in my patient, if the
So why this
contractions
is
are like,
important? Why this differentiation between objective and subjective assessment is important?
so for this particular patient, if the contractions are, let's consider there are 2 to 3 contractions in this patient's in 10 minutes with good intensity, it means her pain is physiologically significant and she's having hypertonic contractions. So there is a correlatability between the contractions and the pain score that is elevated. Depending upon that, we'll know how quickly we have to administer analgesia, how much time we have to administer the analgesia. Based on that, we can select whether we can go for a continuous labor epidural, or we need to give a spinal followed by an epidural, or we need a durapuncture epidural for this patient.
So in this case, like she has type 1 decelerations, what is your technique of choice?
So for this patient, although continuous labor epidural is a traditional choice, I would like to choose durapuncture epidural, sir. And you said the patient BMI is around 46 and we are anticipating a difficult spine. So these 2 points have actually triggered me to choose for a puncture epidural technique. Because like loss of resistance is not always reliable in obese patients. The DPE technique will allow me to confidently confirm that my needle is in the correct epidural space. Because once I enter the dura with a 27 gauge needle and I see the free flow of CSF, it gives me 100% confirmation of the midline placement and depth of the epidural. And also with DPE, I can give a very small intrathecal dose of local anesthetic like ropivacaine with opioid, which gives me immediate onset, excellent early analgesia without any motor block. So with added advantages of the epidural also.
Yeah, so in this case, would you like to enhance your epidural placement? Anything specific you want to do?
So I would like to do a, neuraxial ultrasound, sir, because the patient is an obese patient. So I rely heavily on a pre-procedure neuraxial ultrasound because obesity distorts the surface landmarks and the interface line is unreliable in obese patients having so many skin folds. The neuraxial depth is usually about 7 to 8 in obese patients. And I have noted that the platelet count is also low, having a preeclampsia background. So I can't have a many number of attempts in this patient. I have to make sure that I will have a first attempt success rate. So using an ultrasound, I will assess the exact interspace, the widest space. I'll assess the midline, needle entry angle and all, so that I can keep a longer spinal or epidural needles if required.
So in this case, basically, can you enumerate before you start your regional technique any specific requirement, mandatory prerequisites?
Yes, sir. I can tell it as 5 points, sir. First thing is I will evaluate the mother. We have seen that the patient is obese. She has a background of preeclampsia. Her VAS scores are high. So definitely analgesia is desirable for this patient. I'll see the platelet trends. I'll get the last 4 hours platelet count because to know whether it is in an increasing or a decreasing trend. And I'll assess the spine and also I'll assess the airway before my neuraxial technique. Then I'll see the fetal and obstetric readiness. I'll see the dilatation of the cervix, confirm the fetal well-being by reading the CTG. I'll make sure that the counseling is done to the patient about the procedure. And what is crucial is getting a consent from the patient, giving the patient the realistic expectations of how much the labor analgesia can treat her pain. And during each stage of labor, how the labor analgesia can be useful for her. And what are the risks or complications that can occur, like failure of the technique, post-dural puncture headache, any catheter adjustments that can be needed, or resetting if needed. And you also said that this is an unbooked case, so definitely counseling becomes very important at this point of time. Then I'll need to prepare and monitor. So I'll do continuous maternal SpO2 monitoring, fetal heart rate monitoring. I'll have a larger BP cuff because this is an obese patient with BMI of 46, 48. I'll also insert a wide bore IV line, preload the patient if required, but cautiously because there is a risk of capillary leakage. I'll keep all the resuscitation drugs, intralipid emulsion, naloxone, any vasopressor infusions if required. I'll keep them ready. And definitely a plan B and plan C, since this is a high risk case. Though there are no severe symptoms, but still we are anticipating because it is an obese patient. I'll discuss with my senior colleagues, and also I'll be ready for the complications and ready for GA with the difficult airway card and skilled help ready when required.
So what will be your plan B and plan C in this case if your DPE or if you are failed to insert an epidural?
So if I have failed to put an epidural needle, then I can since the patient has a VAS score of 9 and there is only 2 to 3 centimeters dilatation, she is not ready for this. Obstetrician have not decided for any cesarean section. I can simply give a spinal. I can simply put a spinal needle and 27 gauge Whitaker spinal needle. I can deposit only 2 mg of ropivacaine with 20 micrograms of fentanyl. This will give only analgesia, sensory analgesia to the patient. Then she can cooperate me so that I can properly assess the best space and do the technique. This is one possibility.
So you have given an epidural, let us say your DPEA was successful, and how do you activate your epidural catheter?
So we should understand the physiology of pregnancy, like especially the engorged veins. There can be variable epidural space volume in pregnant patients, and there is high chance of catheter migration, sir. So even before I activate the catheter, I make sure I don't give any rigid test dose of 3 ml of local anesthetic like LOX plus ADR. We don't follow this regimen because the epidural space volume varies in pregnancy and there is high risk of catheter migration. So instead, I treat every dose as a test dose. This means I start with a very low dose mixture, like 0.0625% bupivacaine or 0.1% bupivacaine or ropivacaine. I give it in incremental aliquots, like 3 ml, 4 ml, or 5 ml. And another key point is that catheter may move into or out of the intended space at any time. So I make sure even if the first time I found that it is in the correct epidural space and good analysis is there, for every top up that I give, I'll make sure that I aspirate, and every top up I treat it as a test dose.
Any specific precautions you take when you are threading the catheter? Like how long you want to, what is the length of catheter you want to leave it inside in this parturient with BMI of 46?
With a BMI of 46, the catheter I would like to leave inside is about 5 centimeters, sir, not more than that.
Why not less? Generally, we leave for 3 to 4 centimeters, right?
Yes, sir. But she's an obese patient. We are doing the procedure in a sitting position. And once we make the patient in a lateral position, there is high chance that the catheter can uh, come back, pull back. So there is a risk of catheter pull out. To
Well,
avoid that, we put 1 or 2 centimeters inside.
so this patient, you have left the catheter 5 centimeters, you've activated the catheter with low dose mixture, right? So what is the low dose mixture you want to use in this patient?
So I would like to use 0.08% low dose is 0.1% ropivacaine or 0.1% bupivacaine with 2 micrograms of fentanyl per cc of the solution. Then I'll give it in 3 to 5 ml aliquots.
Total volume?
Total volume, I can go up to 15 to 16 ml as required, but I assess the sensory analgesia, what the patient needs.
Well,
If she's in the first stage of labor, the innovation is from T10 to L1. So I'll make sure the sensory analgesia is there, and I'll make sure I assess the pain scores at every contraction for the first 15 to 20 minutes after I administer the drug.
so you have activated with 15 ml of low dose mixture, and after about 20 minutes, the patient VAS score is earlier was 9 on 10, now she said 7 on 10. Not very comfortable.
So first, whenever an analgesia is poor after activation, I would like to rule out the catheter migration, sir, because there is high risk of intravascular migration, as I already told. So if the catheter was placed clean initially, it can migrate into vessels, especially in pregnant women, because of the engorged veins. So I would like to get a differential of a bloody tap.
The
So if the
aspiration result is
catheter
negative.
if the catheter is not intravascular, the next common issue is usually malposition or catheter migration. So the block may be incomplete because the catheter tip is in the paraspinous space or subdural space or intradural space or a paravertebral space. So I need to assess where the catheter is, and depending upon that, I either uh, pull the catheter by 1 or 2 centimeters and keep assessing, checking for the drug, or I can, if the catheter is completely not in space, you are not able to assess, but she's in huge pain, we can remove the catheter and reset at a different space.
So in this case, what is your plan? You're given,
So,
you have put 5
okay.
centimeters inside. You have activated with 16 ml of ropivacaine fentanyl. What is
So in this case, for my patient, I'm sure that my epidural is in place. So I want to give a numbing dose, sir. So here I would like to administer around 10 to 15 ml of 0.25% bupivacaine or 0.2% ropivacaine to a maximum of 35 mg, because at this dose, it is still not achieving the dose of local anesthetic systemic toxicity. So it should produce numbness bilaterally. Then if no numbness or pain relief, then I would remove or reset the catheter. I would go for a numbing dose for this patient, sir.
So you're given the numbing dose, patient is fine, and she's fairly comfortable, but after about 2 hours or so, there is presumed fetal compromise, and the obstetrician decides to take up this patient for cesarean section category 2. How would you proceed?
All right, sir. So as I have given the numbing dose, I know that my epidural is working. So my first choice would be converting the same epidural into surgical anesthesia, sir. So I'll give a surgical epidural top-up. I'll give 2% lignocaine with adrenaline 8 ml, 1 ml of soda bicarb of 7.4%. I'll give fentanyl 100 mics. I'll give all this mixture of 10 ml incrementally in 3 to 4 ml aliquots over 2 to 3 minutes. I will aspirate each time. I watch for any intrathecal or intravascular signs. And my goal here is to achieve a sensory level of T4 with stable maternal hemodynamics.
Well, the catheter works well in this case, but in case, let us take a hypothetical scenario wherein the patient was fairly comfortable, but when she comes for cesarean section, you have given the surgical top-up, and after about 15 minutes, patient has no pain relief. How would you proceed?
Sir, we have given a numbing dose, we have checked the catheter, but still, if the patient is pain, then we have to think about obstetric causes also, sir. We have to check the nature of labor. We need to check
No,
for
no, no.
bladder distension.
Yeah, she has come for cesarean section. You are given the surgical dose. You are given 16 ml of 2% lignocaine. And now there is no analgesia or anesthesia. Patient is still having pain. So how would you proceed?
So, working catheter, now no effect. So, I would like to define the category of the cesarean section, sir. Like you told, it is
Category
a
2.
category 2 cesarean section already. So, I would definitely go for a regular spinal, or if time permits, since it is a category 2 cesarean section, I might go for a combined spinal epidural also if time permits. Otherwise, I would go for a regular spinal anesthesia and get the case, sir.
Any specific concern in this patient when you are doing again repeat spinal or epidural?
Yes, sir. Since one thing is the platelet count is low, sir. So there is a chances of hematoma if you are not using thinner needles. And second thing is there is an increased incidence of post-dural puncture headache, which needs to be uh, told to the patient about.
Well, quickly, this patient has a wet tap when you're doing a procedure. I'm just troubleshooting this case. Suppose if you are doing DPEA in the first attempt, you have a wet tap. How would you proceed?
Sir, if this patient is having a dura puncture during the procedure, my first choice, our protocol is we do not remove the toy needle, sir. I reinsert the stillet briefly to plug the further CSF leakage. Then I advance the TUI needle by 1 to 2 millimeters to make sure I'm well within the dural opening, the hub of the needle, because the length of the tip of the TUI needle is around 1.8 millimeters. So only the tip of the needle may be in the subarachnoid space. So to thread the catheter intrathecal, we advance the needle by 1 to 2 mm to make it completely intrathecal so that our catheter has to go into the intrathecal space. Then I inject the local anesthetic mixture into this intrathecal space. Since the patient has a vascular high, I instill around 2 mg of ropivacaine with fentanyl. I hold the syringe steady and do not disconnect it because again the CSF and the drug can come out through the same syringe. So I hold the syringe steady. I give a time of about 3 to 4 minutes for the drug to settle. Then I carefully thread the catheter intrathecally. Then I label the catheter clearly that it is an intrathecal catheter. I communicate it with the obstetrician, the labor nurse, and the anesthetist over there, and the entire team that is in the intrathecal catheter. From this point onwards, all the further doses has to be given by an anesthesiologist because even a small dose can result in a high spinal anesthesia. And after that, we can even run local anesthetic infusion using a preservative-free ropivacaine. Then I also counsel the patient regarding the incidence of post-dural puncture headache and document everything very meticulously.
So this case anyway went off very well, uneventful conversion of labor epidural to surgical epidural. What are the post-op instructions you want to write in this particular patient?
So for this particular patient, the post-op instruction, mainly since he is a pre-eclamptic mother, I would repeat the pre-eclampsia profile at 6 hours and 12 hours to know the trends of the platelets, to know the renal and the liver parameters. And also I would like to continue all the antihypertensives, continue the magnesium sulfate protocol as per the department. And I would like to promote breastfeeding and maternal bonding. And definitely, I would like to avoid NSAIDs because there can be renal parameter this thing. So, because of the renal issues, we avoid NSAIDs. We need to evaluate for any hemolysis, elevated liver enzymes, platelet count. We maintain the Iraq protocol, except that we retain the Foley's catheter for about 24 hours. We wanted to monitor the urine output. But definitely promote early ambulation, early orals, and restricted fluid therapy. Mechanical venous thromboembolism prophylaxis should be given. And if the platelet trends are okay, we can also give low molecular weight heparin for thromboprophylaxis. And multimodal analgesia and epidural are continued for 24 hours to 48 hours. If the platelet counts are okay, again, the catheter can be removed on POD 1 or 2.
So quickly, this patient has atonic PPH in the post-operative period. Could we have prevented it intraoperatively by intraop management? You have not emphasized much, or we have not discussed much on this. Even there's a regional anesthesia topic, we tend to forget about uterotonics. So you want to mention something on uterotonics?
Yes, sir. I would like to give oxytocin for this patient, sir. I will give 5 units of oxytocin slow IV over 5 minutes. Then I'll give 5 to 10 units per hour infusion over 4 hours so that we can prevent the atonic PPH.
Yeah. Thank you, Karthik. We'll just quickly move on to the next case. We just got 5 minutes. This is a routine case, primary gravida again, straightforward breech presentation for coming for elective cesarean section, and you're given spinal. So, how would you plan pain management, intraoperative and postoperative pain management? Like, suppose if the obstetrician is a routine habit of externalizing the uterus during surgery, so how do you blunt that and how do you manage?
So I would like to go forward with a straight subarachnoid block, sir, in lateral position with 0.5% bupivacaine heavy, 10 mg with 20 mics of fentanyl and preservative-free morphine, 100 micrograms as an adjuvant. I'll use a 27 gauge Whitaker needle. I would like to give a prophylactic phenylephrine of 50 mics with wedge to prevent hypotension. Then again, the uterotonic oxytocin dosing will be given. I would like to, I have given 100 mics of morphine in the patient, which will take care of the pain management in the post-operative period
Let
also.
us assume patient, you don't have preservative-free morphine available. You are given bupivacaine with fentanyl, and the surgeon, the moment she externalizes the uterus to take sutures, she has pain in the epigastric region. How would you manage?
So the baby has been delivered.
Yeah.
We can
Delivered.
go forward with
The uterus is externalized, and she
yes,
has
sir.
pain in the discomfort in the epigastric region.
So first we'll verbally speak with the patient and counsel her about the temporary nature of the thing. And I inform the obstetrician to put the uterus back into the abdomen since sometimes the pulling of the ligaments and all can cause the sensation in the patient, and it can also cause a sensation of nausea sometimes. So I would like to give a prophylactic ramoxicillin, and definitely IV fentanyl can be given. And for the post-operative period, I will give a regional nerve block like a transverse abdominis plain block for this patient.
So what are all the regional pain blocks options do we have in this patient? If
So,
given a choice, which one will you prefer? Which is better? Which is superior as per your experience and as per the studies?
as per the studies and as per my experience, definitely the gold standard is always intrathecal morphine, sir, compared to any other facial plane block. But wherever the preservative-free morphine is not available, there are techniques like tab block, transverse abdominis plane block, or the quadratus lumborum plane block, or sometimes ilioinguinal iliohypogastric nerve block. These can be given, but definitely, except for the QL block, other blocks do not give a visceral analgesia. But intrathecal morphine is a simple technique. It is happening intraoperatively, and it is also giving visceral and somatic analgesia postoperatively. And these blocks will need expertise. They are little difficult to perform. You have to know the anatomy and solar anatomy. Maybe you have to be a regional anesthetist to perform a few blocks. And coming to the intrathecal morphine, it will provide prolonged duration of analgesia, and it will cover both somatic and visceral components, as I already told. And there is less opioid consumption in the post-operative period once you give a few
What dose of morphine you want to give? Intrathecal.
Intrathecal morphine, 100 micrograms.
And what is the incidence of respiratory depression?
It is very low, sir. Like it is less than 1%, definitely, as per our experience.
Can you enumerate the prospect guidelines following cesarean section?
Yes, sir. The prospect guidelines can be divided as preoperative, intraoperative, and postoperatively. So preoperatively, even the prospect will emphasize on using epidural morphine 2 to 3 mg during the epidural, and also intrathecal long-acting opioid like 100 mics of morphine. It is emphasized even by the prospect. You can give oral paracetamol before the cesarean section. And during intraoperative period, intravenous paracetamol is administered. NSAIDs at the end of the surgery, if the patient renal parameters are okay, intravenous dexamethasone can be given. And intrathecal morphine, if it is not used, you can go for a tab block or a QL block or a erector spinae plane block in this patient. But of course, they'll need change of position of the patient. And post-operatively, oral or intravenous paracetamol can again be given. And NSAIDs, if there is no contraindication, opioids can be used for rescue. And analgesic adjuncts include like transcutaneous electrical nerve stimulation may be used. And we should emphasize that the obstetrician uses the proper surgical technique. One recommended by the prospect is Joel Cohen incision and non-closure of the peritoneum and usage of the abdominal binders.
Any specific thing on Iraq bundle and your regional pain relief?
So post-operatively,
yeah, I think we are done. I think we conclude our session, Dr. Sangamitra. Thank you very much for the opportunity. Yeah.
Thank you so much, Pandya sir, and thank you, Karthik. It was a wonderful presentation. Now, before we move ahead with our last session, I would like to make some announcement. Tomorrow's session will we will log in at 5:45 p.m. and we will start a bit early. To start with, we will go ahead with Dr. Sandeep Diwan's talk on discussion with Dr. Naveen, and the topic will be the discussion on TKR. So we are starting a bit early tomorrow. So please log in by 5:45 and we'll start the session by 6 o'clock. And we have some case discussions, exciting case discussions tomorrow, along with a interesting quiz and a PBLD session too. So do join tomorrow. I will go ahead with today's last session. That's a case discussion on awake breast surgery by Team Ruby, by my guide Dr. Neeta D'Souza ma'am, and her fellow Dr. Tejas Wagh. Good evening, ma'am.
Very good evening to all. I'm audible, Sangam?
Yes, ma'am. Yes.
Again, it is a very nice initiative, so I congratulate Team Mayora. I thanks Sangamitra for all the meticulous and the seamless coordination. I know it takes a lot of time and lot of effort. Thank you so much. I think it is instrumental in organizing this. And Tejas, relax. Okay?
Yes, ma'am.
Let's go and start. So Tejas is going to be presenting awake breast surgery. Let's see how it goes. Yes.
Ma'am, I'm audible, ma'am?
Yes, you are.
Yes, ma'am. So I'm starting with the case. So my patient, she's 74 years female, Mrs. Ranjana, resident of the
Tejas, you
Pune.
can make it full screen, please. Tejas.
Okay,
Yes.
sir.
Yeah.
Okay. She presented with the complaint of the lump over the left breast since 5 to 6 months, and she started the complaining of the pain over it since 1 month. She is known case of the hypertension, ischemic heart disease since 5 years, and she had the history of the palpitation in 2016, for which ICU management was done. Her recent angio is done with suggestion of the triple vessel disease with a mild plaque in the LCX, severe calcification in the proximal LED, and mild calcification in the RCA. On echo, she has a reduced EF of the 30 to 35%. She is taking tablet Telma 40 mg, tablet Evapret 5 mg, and tablet Clopidogrel 75 mg. Previously, in 2021, she underwent total laparoscopic hysterectomy, following which she had the history of the delayed recovery from the anesthesia. Coming to examination, she is averagely built with a weight of 64 kg, height of 163 centimeter, with BMI of the 24.1 kg per meter square. Vitally, heart rate is 78 per minute, with BP of the 160 by 78 millimeters of mercury, and room air saturation is 98%. She had a reduced cardiopulmonary reserve with a breath holding time of 18 seconds and effort tolerance of 1 to 2 minutes. Rest physical systemic examination, spine examination is within normal limit. On investigations, his HB is 10.2 with counts of 9,200 and platelet counts of 1,24,000. Her creatinine is 0.9, INR is 1.02, and ECG is suggestive of the TVO inversions in inferior leads. So the summary is 74 years female with lump in breast since 5 to 6 months, known hypertensive, ISD, triple vessel disease with reduced EF, and past history of palpitation and delayed recovery of from anesthesia and reduced cardiopulmonary results is posted for the left-sided mastectomy in view of the CA breast. Since the patient is high risk and the patient is having the previous history of the delayed recovery, the patient and the relatives of the patients, they are little anxious about the to perform the case under the general anesthesia. Hence, they have asked for any alternative techniques to do the procedure and for the awake techniques.
So you have planned, the patient is already posted for a mastectomy, and you
Yes,
have
ma'am.
already seen the patient and reviewed the investigations. You have already have a plan in mind, and you plan to go ahead with awake breast?
Yes, ma'am. Before going with the plan, but I would like to have some words with the surgeons. So we also need to inform about the extension of the complete procedural plan and the extension of the surgery about the involvement of the any axillary dissection, and if there is any flap or anything is required for the surgery. So accordingly, we will decide our plan, and also for deciding, we need to consider the anesthetic considerations also. As if we are planning for the awake surgery, so there will be the uh, multiple regional techniques we need to take, considering the innervations of the breast, as it has a complex innervation. So there will be the multiple punches, and also we need to drug volume and the concentration of the drugs which we are in, we need to consider for that also. And it has to be pre-calculated.
So what would be your actual considerations with regards to the patient surgery, and the pathology is cancer? So what are the considerations before you proceed for awake breast surgery?
As in this case, ma'am, the patient is known hypertensive and most of he is having the cardiac issues. So also, if we are planning for doing the awake procedure, so we have to completely explain the patient about you will be awake during the procedure, and means the duration of the procedure, and also means they don't have to do any movement, and there will be some patients uh, should not have any psychiatric history, and they should be able to understand the awake procedures, and risk of claustrophobia if patient is having, we have to look at before going ahead with the awake procedure.
So in which patients can you actually plan an awake breast surgery? Can all patients undergo this? Or is it
Uh,
for a select
for
few?
the for, for the first for the awake breast surgery, we can plan if the first for the patient, if patient is requesting and the patient is anxious. Secondly, with the patient with poor cardiopulmonary results, patient with end stage renal disease, and with the acute liver disease also, and patient having history of the malignant hypothermia, and also with the uh, considering the immunological and the oncological concerns, we can go ahead with the awake breast surgery.
So you mentioned that awake breast surgery requires multiple injections. Can you elaborate on that, or can you explain the anatomical innervation of the breast?
Yes, ma'am. So breast is mainly innervated by the anterior and the lateral cutaneous branches from the intercostal nerves, then supraclavicular nerve from the cervical plexus, and the axillary region is supplied by the intercostal brachial nerve and the medial cutaneous nerve of the arm. While the myotomal innervation is from the brachial plexus, we have the lateral pectoral nerve, medial pectoral nerve, then the long thoracic nerve, and the thoracodorsal nerve.
Is there any role of knowing the osteotomal supply?
Yes, ma'am. If the tumor is encroaching into the osteotomes, then we need to cover the osteotomal supply also for performing awake surgeries.
You have
And if there
mentioned,
is a
yeah, okay.
flap, if we are performing any, they are performing any flap procedures.
With regards to, since you mentioned flap procedures, pedicle flaps, is there any other concern that you have? if there is a pedicle flap done for this patient. Now, patient is undergoing mastectomy. If they do a pedicle flap and the local flap for covering, there's a big defect when they remove the breast. And the patient
Yes,
wishes
ma'am.
to.
So we can't give any regional techniques near to the flap as they are doing the microanastomosis also. So we need to avoid the regional techniques near the flap. So we can go little bit away from it. So we can plan the different flap also. Like in case of the if they're planning for the LD flap, we can go ahead with the other techniques like we can give erector spiny block for the post of analgesia.
You
Or
mentioned that, yes, you mentioned intercostal nerves. Which level of intercostal nerves? Is it all 1 to 12? Which are
no,
involved in the
it's from
breast?
the 2 to breast, mostly from the 2 to 6 intercostal.
So if it's an LD flap,
LD flap can go ahead with the inside lower level at T7 or T6.
now you mentioned that there are various blocks which can be done. What is your plan? How will you go ahead?
So for my case, I am planning for the plan A for my case is the multi-level thoracic paravertebral block, which is USG assisted, and to placing the catheter at the T4 level, and followed by the interpectoral and the superficial serratus plane block, along with the local infiltration at the supraclavicular region and the parasternal region.
What about the axilla?
Axilla can be covered with the superficial serratus anterior plane block, or we can give infiltration.
Can you describe how will you do this?
Uh, for the paravertebral block, so after taking the consent and we'll take the patient in the operation theater. We'll attach the monitors and we'll check for the IV access. And for performing, I will be doing the case under the procedure under the sitting position. So by the side of the OT table, and as it is a USG assisted, I will like to pre-scan and to know the actual space and the depth of the transverse process and the pleura. So under all aseptic precaution, we are using the 18 gauge 2A needle using by the loss of resistance technique to air and the saline. We'll first mark the spinous process and the 2.5 centimeter lateral to the spinous process. We'll go perpendicular to the skin. We'll hit the transverse process. So it should not go more than the 4 centimeter. After hitting the transverse process, we can move either cranially or caudally, but not more than 1 centimeter to get the loss of resistance of the superior costotransverse ligament. And after we'll confirm with the negative aspiration and the loss of resistance to air and the saline, we will inject the drug for this patient as it is a multiple techniques we are doing. I will like to go with the 0.5% ropivacaine with 5 to 6 ml at 3 levels, to T2, T4, and the T6.
You mentioned putting a catheter in the paravertebral. Which level are you putting the catheter?
Catheter at T4 level, ma'am, but it should not be more than 2 centimeter.
And you said it was USG assisted?
Yes.
You mentioned USG assisted.
Yes, ma'am.
How has the ultrasound helped you?
Ultrasound, what, ma'am? Sorry.
How has the ultrasound helped you in sighting your paravertebral space?
With the ultrasound assisted, we can come to know the depth and the
level. Can you know the level?
Yes, ma'am.
So
we can
how
even
do you know
identify
the
the
level?
So first, for this, I'm choosing the curvilinear probe. So we'll place the probe at the above clavicle. From that, we can scan backward. So from the rib level, we can count the ribs. So the first rib below the clavicle will be the first rib, then second, third probe. Accordingly, we will move medially to look for the transverse process, and we can also get the superior costotransverse ligament.
This was the paravertebral. You've mentioned 0.5% ropivacaine. Can you enumerate on why are you giving the pectoral block? Paravertebral covers which part of the thorax?
Paravertebral, it will cover, as we are giving the multiple levels, so it will cover from the uh, T2 to T6 levels. But for the covering the brachial plexus component, we need to give the other blocks like the interpectoral and the superficial serratus plane block.
Can the paravertebral be given with PNS guidance?
Yes, ma'am. We can give with the PNS guided. So with the for this, first we will set the PNS at 1 milliampere, and first as a landmark technique, we can go ahead. First, after entering, there will be the first twitches of the paraspinal muscles, and once we enter the superior costotransverse ligament, so there will be the we can reduce the current, and the twitches will be of the intercostal muscles where we can confirm and deposit on.
So you have given the paravertebral, you have given the interpectoral, and you have given T2 infiltration in the axilla. Anything else have you given? You have given SAP as well.
Yes, ma'am.
Which is it? What is the difference between the superficial or the deep, or is there no difference?
Superficial has more coverage, ma'am. It will covers the intercostal nerves, lateral intercostal nerves, along with the thoracodorsal and the long thoracic nerve, and also for the intercostal brachial nerves. While with the deep SAP, it will cover mostly the lateral intercostal nerves.
So is blocking is thoracodorsal and the long thoracic, are they sensory nerves?
Yes, ma'am.
They
Sensory
provide.
and motor also.
Are they majorly
supply.
sensory or are they majorly motor?
Motor.
So do we really need to block thoracodorsal and the long thoracic for every breast surgery?
No, ma'am. For every surgery, we don't require, but depends on the procedure. Like any flap is there, that time we need to block. And also, they try to preserve the long thoracic nerve during the procedure to avoid the winging of scapula. So we need to no need to block.
Okay. And such patients who undergo awake breast surgery, do you plan to have some sort of sedation, or what is the strategy for that?
Yes, ma'am. As this patient is a high risk, so I will like to use the conscious sedation strategy along with to maintain the Ramsay sedation score around 2 to 3, and we like to avoid the hypotension and tachycardia during the procedure. So there are various options. So we have dexmedetomidine at the 0.2 to 0.3 microgram per kg per hour. Then others we can use the midazolam in incremental doses, and fentanyl as a we can use as a rescue, and also we have the can use the TCI TIVA technique also. So in that you can have remifentanil and the propofol at the 1.5 to 2 microgram per ml at for the plasma site concentration.
With a BIS monitor or without is also fine.
Yeah, BIS monitor you can use with to maintain the BIS around 60 to 80 for sedation.
The surgery starts. Did you mention what specific monitoring will you have for this patient since the patient is cardiac? Do you think that you need to have any additional monitoring?
And for monitoring, I will like 5-lead ECG on invasive blood pressure monitoring and the saturation. Along with the ETCO2, we can monitor through the face mask, and arterial line and the central venous catheter will be depends on the if the patient's BP is labile and or if it is unstable, we can go ahead with the arterial line also. And other monitors we can have can check can do the quick focus to confirm the to look for the IVC assessment, and cardiac focus also we can do. And this, as already mentioned, and can have the 2 wide bore IV cannulas if
What
we
if
are not.
What if this plan fails? As in, how do you assess before the surgeon starts? How will you call this? Like if the paravertebral doesn't work, so how are you going to check assessment of
Ma'am,
work?
assessment will be done for the complete anesthesia. We can wait for the 30 minutes and we can assess with the cold cold sensation or the pinprick sensation. And if it doesn't works, so we can ask the surgeon if we can uh, repeat the procedure once again, means can postpone and do it again one day after, or we can go ahead with our next plan. That is, we can go ahead with the plan B of the general anesthesia
So you're
after
ready to
30
give
minutes.
general anesthesia, but the patient's wish was not to receive general anesthesia. So you think of postponing because it's an elective procedure, or how will your plan proceed?
If it is elective and the patient is not willing, we can postpone and we can again go ahead with the regional the next time.
Okay. Can you quickly describe the paravertebral space to me? The
Yes,
boundaries?
ma'am. Paravertebral, it is a wedge-shaped space, and it is bounded anterolaterally by the pleural space and the lung parenchyma, and medially by the vertebral body, vertebral disc, and posteriorly by the superior costotransverse ligament, and laterally there is a intercostal membrane and the intercostal space, and the space is divided into anterior and the posterior by the endothoracic fascia. And posteriorly, ma'am, it is incompletely formed by the superior costotransverse ligament. There are previous cadaveric microCTs studies are done, which suggest that the thoracic paravertebral space, it is a narrow, with the posterior intercostal vessels. They are very close to the pleura, and it is SCTL. It's incompletely formed the posterior wall between the internal intercostal membrane and the vertebral bodies. And hence, if we are depositing the drug outside the SCTL, it can seeps into the paravertebral space to act as a paravertebral.
So with regards to paravertebral, are there any complications that you look out for?
For the complications, general complications will be the hypotension, followed by the then vascular punches, pleural punches, and the pneumothorax. The hypotension is around 4 to 6%, while the pneumothorax we have 0.5% complication rate. And others are the epidural spread, then intrathecal spread, chance of last, and no trauma or any other injury.
With regards to paravertebral, do you actually observe any hypotension, or there is no hemodynamic compromise at all?
Ma'am, if there is a fall from the BP more than 20% from the baseline, we call this as hypotension.
Yeah, but does
Because
it
of
happen with a paravertebral or it doesn't? Does the sympathetic blockade happen with a paravertebral?
yes, ma'am, it happens with the parrot.
What about heart rate changes while doing the block? Can that also be possible?
Heart rate, yes,
Arrhythmias?
ma'am, can
Why
be
so?
possible. First,
The content of the
can be
paravertebral space? Is it to
content
something
it.
to the content of the paravertebral space? Why may we have rhythm changes?
It has a dorsal ramus, rami communicantis, and the sympathetic chain anteriorly, and also the adipose tissue into which there is a thoracic spinal nerves lies and the intercostal vessels. So again, the second cause for this thing is the drugs which you are using. If you are considering this patient as a cardiac patient, if we are using the lignocaine adrenaline as a drug, so that can also cause the tachycardia and arrhythmias if it is goes into the vascular.
While locating the paravertebral space, is it as advisable to use like Sika solutions or xylocaine adrenaline?
Ideally, combination means mixing of the drug should not be done. But as a vascular marker, we can use the lignocaine adrenaline. But should be avoided if cardiac patient is there.
With regards to guidelines, patient was on clopidogrel.
Yes.
So you have taken a cardiologist clearance, and are you okay? What are the other, say, a bridging therapy, or what else would you consider prior to? Is it okay to give paravertebral? Is it similar to a spinal epidural while considering guidelines,
Uh,
extra guidelines?
yes, ma'am. Cardiology reference is taken about the bridging therapy and the stoppage of the clopidogrel also. So considering the as per the ASRA guidelines, as the paravertebral blocks we are giving near the neuraxis. So the both the considerations are same as for as like the ASRA guidelines about the uh, clopidogrel also. Hence, we need to stop the clopidogrel 5 to 7 days before the block.
With regards to comparing paravertebral and the pectoral blocks, I mean both the interpectoral and the pectoserratus. Are they similar or there are differences between them? Or which would you prefer? When?
So for complete anesthesia, we need to give the paravertebral block, and for the analgesia, if we want, we can have the paravertebral and sorry, interpectoral and the pectoserratus.
So the
And
pectoral blocks are for analgesia or surgical anesthesia?
pectoral block we can give for the surgical anesthesia also and the analgesia also. But if we want to do the completely under the awake procedure, means so we need to give the paravertebral block.
So the paravertebral you said covers the from
T2
T2 to
T6.
and so
Yeah.
and the pectoserratus covers from the interpectoral and
Dermatomus.
the pectoserratus? You said
Pectoserratus will cover the
covers which area? Which
lateral
area of the breast? If you
lateral
divide the breast
cutaneous
into
nerves,
4
ma'am.
quadrants, so which quadrant will the pectoserratus cover?
Upper outer and the lower outer quadrants, pectoserratus.
So there is an overlap of the areas which you are blocking. You're giving paravertebral also and you're giving interpectoral also. Why is it so?
To have the more dermatomal coverage, ma'am, and also the for the axillary clearance also we need to give the pectoral blocks also.
So you mentioned recent CT imaging studies, micro CTs.
Yes.
Some imaging studies were done that revealed more about the superior costotransverse ligament.
Yes, ma'am.
So can you say some more points? Like, is it a fixed space? Is it it's just like a boundary? Or can you elaborate on that?
It is a boundary, ma'am. Means it is a retro-SCTL boundary which communicates with the thoracic paravertebral space via the slits and the costotransverse space, intervertebral foramen, and with the erector spinae compartment.
So which are the other paraspinal blocks which may be considered for analgesia, if not for surgical anesthesia?
For this, we have, ma'am, erector spinae plane block, then the intertransverse process plane block, then the rhomboid intercostal subserratus plane block, and the serratus posterior superior plane block. And for the
You will be
other for the lateral side, we have for anterolateral we have another is the Brilma, which covers the
what
lateral
is Brilma?
cutaneous.
What is Brilma?
It is a branch of the intercostal nerve at the mid-axillary lines. So there are two. If you are giving it at the fourth and fifth level of the rib, it is a Brilma, and for the modified, we are giving more caudally at the seventh and the eighth ribs. Eight ribs.
If there is a lesion or extension of the tumor very close to the sternum, so what other block may need to be considered if you're planning a awake breast?
And we have, ma'am, parasternal blocks for the near to the sternum. So those are the pecto-intercostal facial plane block and the transversus thoracic plane block, where we are blocking the anterior cutaneous branches of the intercostal nerves.
Can you summarize the prospect studies for the oncological breast surgeries? Just the
Yes,
takeaway
ma'am.
points.
So prospect is mainly for the oncological breast surgeries, those for the minor and the major breast surgeries. So for the pre-operative and the intraoperative, so they suggest to give the paracetamol, NSAIDs, and COX-2 inhibitor, along with we have gabapentin, dexamethasone, and local infiltration. And for the major breast surgery, along with this, we have the paravertebral blocks. If it is contraindicated, to go with the pectoral blocks.
How about opioids in breast surgery?
Opioids, they have asked for the post-operative analgesia only for the rescue analgesia, as a rescue analgesia, post-operative.
One thing is, do breast surgeries actually require blocks? How will you justify? They can be managed with GA and multimodal anesthesia. So can you give the last justification?
For this, actually means there are some studies are done about the recurrence of the anesthesia, recurrence of the breast cancers after the surgery. So actually means there is no.
How do breast blocks help? Do they help?
The risk which for the along with the regional anesthesia, 6% risk from the studies, and along with the general anesthesia, there is an increase in the risk about the 24%, because the volatile agents and the opiates which we are using during general anesthesia, they suppress the immune function and they activate the hypoxia inducible factors and the VEGF, which supports the angiogenesis and also promote the anti-apoptotic pathway.
Chronic pain?
Some for the propofol, it has some better outcome as it reduces the inflammation and can inhibit the hypoxia inducible factor and VEGF.
Any renal chronic pain?
Yes, ma'am. Also, there is a reduction in the incidence of the chronic pain following regional anesthesia.
We'll summarize. Thank you. Thank you, Tejas.
Thank you, ma'am. Thank you.
Thank you, Neetu. Thank you.
There are many more questions that can be asked, but I think I heard the anthem and the bell. So I think we will conclude before people go off to sleep. Thank you so much. It was nice.
Yes, we have limited time, but so as far as it goes, everybody has covered the topic very well. Thank you, Tejas. With that,
Thank
we
you, ma'am.
come to an end to today's session. I personally thank Dr. Javed sir, Dr. Hetal sir, Dr. Amit sir, Dr. Archana ma'am for the wonderful intro of today's session. And presentation by Dr. Ritesh sir, Dr. Pandya sir, Dr. Somita ma'am, and Neeta ma'am's fellow. I understand that 30 minutes are the very short time to cover such important topics, but it was very well managed. We will all meet tomorrow at 6 p.m. And I thank you, especially the team G, Priyamvada, Shweta, Gautam, and Sharad for taking care of the digital content of today's fellowship assembly. Last and not the least, I thank all the fellows who have taken so much of effort. Believe me, it is not easy to talk 30 minutes on a topic online where everybody is listening to you and you are being judged constantly. Hats off to you. You all have taken a lot of effort and it really showed off today well. And to all the delegates who have made this session successful, we had more than 76 participants today. So let's keep the enthu on and meet again tomorrow by 5:45 p.m. Please log in so that we can start our session with first lecture by Divan sir at 6 p.m. tomorrow. Thank you so much, team Eura.
Thank you so much. Good night.
Good night, ma'am. Thank you.